Well, hello there, everybody. It is again a Saturday evening, and I'm recording another video from my home gym location. Probably by now, most of you have figured out that is where most of my videos are recorded from. Today, I'd like to speak to you all about occipital nerve blocks for headaches. There are a variety of nerve blocks that we can perform in our office for headaches, but for the sake of this talk, I'd like to just focus on occipital nerve blocks. What I'm going to do today is go through a variety of anatomical pictures. It's going to be very easy to lose you all, so please bear with me. I'm going to try to describe these things the best that I can. What I like to do first is talk about the cervical spine region because this is very important. I would just make a comment here. If you are seeing me as a patient for the very first time for headaches, and you're over the age of 50, I already know, before I even walk into the room, I already know that you're going to have some neck pain issues. The neck is a very important region to focus on, sometimes when it comes to occipital headaches or posterior headaches. And over here, this little cartoon here, this is not the best cartoon. I will provide you with some better pictures later. In the back of your head here, you have all these little nerves under your scalp, okay? The greater occipital nerve, the lesser occipital nerve, the third occipital nerve. And if you place your finger behind your head here, that little notch here, that little bump in the very center of the back of your head, the occipital protuberance, if you just move your finger slightly towards your ear, you'll feel your fingers kind of just fall into a little divot. Okay, and those little notches are where we insert the needles, and we try to get underneath the layers of your scalp, underneath all the tissue and muscles beneath, to inject local anesthetic and sometimes some steroids in around these nerve areas. Now, here's the thing. If you were to dissect a human neck and remove all the layers of muscles and skin and fat and ligaments, you could trace all of these nerves, all these occipital nerves back to your C2, 3, 4, 5 level of your cervical spine. These nerve roots here, okay? And unfortunately, in this slide, I have a lateral view of the neck. We're not taking a posterior view, that is from this end. We're looking at it straight on from the side here. And the reason I make a comment about that is these little joints here that I'm pointing out, those are your facet joints. Notice they're kind of like little hills. So when you move your neck side to side, these little joints kind of slide up and down on each other. And it's very common for individuals to have little osteophytes and arthritis of those joints. And these little foramina, these little holes here, where these nerve roots come through, they get pinched or snagged very easily. So this is why sometimes, as I was saying earlier, if you're over the age of 50, I already know you have some neck arthritis or some issues. And that is why if you have some upper neck problems, you're going to have some pain referred to the occipital part of your head. And just the way these pain circuits work, you'll also have some of that pain transmitted up through the back of your eye, other areas of the scalp as well. The question that can confuse some people is the following. How is it that I can have migraines, horrible headaches all the time, and yet you're telling me that if you inject my upper neck area or the back of my head, my occipital area, that it's going to help with my headaches somehow? Or the opposite, how is it that I can have a neck issue and that can lead to a great number of headaches? What I have here before you is a very oversimplified diagram that explains how this works. In reality, it is very, very much more complicated than what I am going to explain to you. I'm trying to make this very simple. If you look at a person's brainstem, okay, there is a great number of cells and circuits that run through the brainstem. It's a very tightly compact area of your brain. So, for example, when I see patients that have strokes, what I explain to the stroke patients are that the reason why you can have a very, very, very tiny stroke in your brainstem and have such a profound effect is because it's a very small area and a great number of circuits flow through the brainstem. So the trigeminal nerve, okay, basically all the sensation of the anterior 2/3 of your head, your face, your sinuses, everything in that region perceives pain through the trigeminal nerve, okay? And likewise, if you're going to have some upper neck pain, as I showed you on the previous slide, mostly C2-3, sometimes 1 and 5 on the other ends have some input into the brainstem as well to signal that, hey, there's some pain going on in these areas. So to answer the question, how is it that neck pain can cause migraines? How is it that migraines can cause neck pain? Think of it this way. These circuits are essentially going through the same area. Okay, so maybe a better way for me to describe it is this, okay? If you and I are parking our cars in the same parking lot, if I park next to your car, what happens if I go over the yellow line? Technically, we're different cars. We're in different parking spaces, but I went over to the yellow line a little bit, so we're kind of squeezed into the same spot, kind of, sort of. It doesn't matter a whole lot, I suppose, unless you want to get in and out of your car and you're blocked in on that particular side, or one of us opens our door really fast and dings the other car. But think of it this way, okay? Maybe another way for me to describe this. If my phone goes off, let's say that I receive 3 phone calls at the same time. If I receive 3 phone calls at the same time, here is what would work out the best. I would answer the first call and say, thanks, can you please hold? I'd go to the next call, the second caller, and say, thanks, could you please hold? Then I'd go to the third caller and say, thanks, can you please hold? Then I'd go back to the first caller, take that person off a hold, address what it is that they want, talk to them and say, okay, thanks, and then go on to the second person and finish all my 3 phone calls. That is what would work out the best. But what if that's not possible? What happens if all 3 phone calls are coming through at the same exact time? What if I can't put one of the callers on hold? Well, the obvious would happen. We'd have 4 conversations at once, 3 people trying to talk to one person. Signals would get crossed, would they not? Messages would get crossed. Maybe the first caller wants me to go out to dinner with them, but maybe the third caller wants to come over to my house to borrow something, and the second caller, maybe they're yelling and screaming at me about something they're upset about me with, and by the end of the day, I can't figure out who's talking to me or what they want. So this is kind of sort of what happens when you have pain signals coming in from the cervical area and from the head area in a tight little compact space all at the same time. And again, it's more complicated than what I'm showing you here. There's certainly modulatory pain signals that descend from the brain. There's all types of ascending circuits as well. But basically, for lack of better words, things get messed up. Wires get crossed, signals get crossed, and next thing you know, if you have chronic migraine or pain all the time in the head, you're going to get neck pain and vice versa. So here are some nicer pictures to look at. So as I was saying earlier, this is more your posterior view. Now we're looking directly at the back of somebody's head or the back of their spine. Here are your third occipital nerve, your greater occipital nerve, and your lesser occipital nerve. So again, if you were to place your finger behind your head, eventually you'd feel these little notches. It's kind of that ridge that goes right across here. You can get all these nerves, okay? So if we do an occipital nerve block in the office, here's the problem that arises. The way that I do an occipital nerve block is not the same as the next person that comes in the room. Neurologists, headache specialists, pain doctors, we all do these things slightly differently. There's some variance into how we do this. And that may be one of the reasons why we don't have good studies for these types of procedures in some cases, because we don't have a standardized way of doing these procedures. What you'll see here when you go down the neck area, right? As I was saying earlier, if you have a neck issue, right, your pain providers, your interventional radiologist and your anesthesiologist, they're very comfortable doing, say, epidural nerve blocks at C5, C6. But if we were to say to an anesthesiologist or a pain doctor or an interventional radiologist, hey, I would like my patient with headaches to have a C1 nerve block or a C2 nerve block, why is it that you will not find individuals that will do this? Okay, take a look right here. You see this? This is your vertebral artery. Okay, and here's your C1 nerve root. So if you come down here, right, if I place a needle down here at C5 around this facet joint, I'm not close to that vertebral artery. And if we take a look up in this region, a little more blown up over here, again, you can see right there, right? If I place a needle here or close to this area with local anesthetic and steroids to try to block the C1, if I go just a little bit too far, I'm getting kind of close to that artery. And if I go just a little bit further here, if I breach this ligament, this posterior longitudinal ligament, well, what's behind that? The spinal cord, okay? That could cause some really bad things to a person. So essentially, if you want to do a nerve block in these areas, or an epidural block in these areas, you need somebody that is definitely going to do this with image guidance, with fluoroscopy or a CT scanner. You do not want somebody to go in that area blindly. When we do occipital nerve blocks, we place a needle up here, okay, up in this area. So basically, if I were to place that needle too far, I'm just going to hit skull, okay? I'm not going to cause harm to you whatsoever. There is an exceedingly low risk of causing harm with that procedure versus down here doing a C1 or a C2 nerve block. Now this is a slightly different picture. What I want you to appreciate in this picture that was not in the last picture would be all these layers of muscles, everything we have to pass a needle through to do these procedures. So I'm going to explain to you in this slide, or give you a little bit of an overview as to how I perform these procedures for my patients and what I believe is the most effective. A couple years ago, there was a very nice abstract presentation at the American Headache Society by a physician who did a nice review on the procedure of occipital nerve blocks. And I kind of sort of agree with the way he does nerve blocks, okay? And I've sort of adopted his method and modified it to my own approach. So the way that he suggested we perform the method would be to place the needle into the occipital notch. Again, you can feel that in the back of your head. Use a 2-inch needle and go directly across this occipital ridge, okay? Bury the needle all the way across the occipital ridge. And then as you're withdrawing the needle back, deposit all your local anesthetic with steroids, if you do include steroids in your inject it across that pathway there. That way you're blocking everything. You're blocking the occipital nerve, the lesser occipital nerve, and a third occipital nerve. You're giving your patient a great deal of pain relief. Now in my clinic and in the areas where I've practiced, I've never had the luxury of having a 2-inch needle. I only have a 1.5-inch needle. If I go to the hospital, the hospitals only carry a 1-inch needle. You can certainly get a nice long needle if you use a spinal needle. However, those are lower gauge needles, so they're fatter, they're thicker. It would cause more pain and discomfort for the patient. So if I want to use a 25 gauge needle and therefore make the procedure less painful, sometimes 1 inch, 1.5 inches is all that I can get my hands on. I used to use 27 gauge needles, which are a little bit thinner. However, my problem with 27 gauge needles was that when I buried the needle into all these muscles and layers, it was very difficult to get that local anesthetic deposited fast, okay? You want to get the procedure done in a more expedient manner. You want to do it faster so the patient has less discomfort. So what I tend to do is I tend to find the notch here and place the needle in and deposit some local anesthetic around the lesser occipital nerve. Then I do, just as Dr. Matthew, I believe it was, that did the presentation, suggested, go straight across your ridge and deposit more along your greater occipital nerve. But then I also would draw the needle and get back here. You don't see the third occipital nerve here, but if we trace things here, again, we could be down here. That's a little more dangerous. And again, as I pointed out in a previous slide, right through here, if you start burying around this area, you're going to get around arteries and major structures. You don't want to do that. But right here behind the mastoid bone, that's where you get yourself near that third occipital nerve. So I tend to inject inward toward the ear and fan out in different directions. In each little area, I tend to fan out my injectant, my local anesthetic, and sometimes we do include steroids, so that therefore I am covering a very large region with my local anesthetic, okay, and I am able to provide a greater pain relief. Years ago, well, let me just back up for a moment. When I first learned how to do occipital nerve blocks when I was in residency, my attendings suggested using 2 to 3 cc's of local anesthetic. And what I would do in those cases, in reality, I would go after the most painful area, okay? In reality, if most of your pain was over here by the third occipital nerve, I would block there. If most of your pain was a little more toward the middle here by the greater occipital nerve, I would inject in that region. And then when I went to a Southern Headache Society meeting, there was a well-known headache specialist, John Rothrock, which suggested using 10 cc's of local anesthetic, which I thought was a little bit extreme at the time, but now it makes more sense to me because you're technically blocking 3 nerve regions. So technically you're getting 2 to 3 cc's, maybe a little bit extra in each little area, and you're covering a wider area with that volume, and you're providing much greater pain relief. The downside of that is, as some of you know, if you've had nerve blocks with me, when we're all done, it's quite lumpy back there. I mean, you can really feel the lump and where I injected the local anesthetic. As well, if I am very generous with local anesthetic, half your scalp back here, you know, where I have my hand, that may go numb. And if I don't warn patients that could happen, sometimes it may freak patients out, so to speak, because they can't feel their head. And so I usually do warn patients nowadays that, okay, look, if your skin goes numb, don't worry about it. It will come back. But the idea is to provide some pain relief in these areas. Now, the common questions I'm asked are, how long is this going to last? The answer is it's different for everybody. There are some patients I have that if they're really severe cases, they do have their nerve blocks performed between their Botox sessions, so they come in basically every month and a half, every 6 weeks, and have a nerve block done, and they do just fine. There are some patients that can go several months. And there's some patients that may tell you that, hey, look, you know, it kind of worked, but it only lasted a few days. Now, there are some other procedures you can do that I don't personally get into. So when we do nerve blocks, we're modulating pain. Okay, we're not ablating nerves, we're modulating pain signals. So certainly there are procedures where you can actually cut these nerves. Okay, there is such a thing as an occipital rhizotomy, which is a major surgery where they remove part of your occipital bone here and literally cut these nerves down at the C1, C2 level, as I showed you at the previous slide. Very effective for pain control. It will work, but you also have permanent numbness of your scalp. And as I was saying, you can get down to the C1, C2 dorsal rami, those nerve roots themselves, but because it's a little more dangerous to go into those areas, it's beneficial to have somebody do it with proper image guidance, either a CT scanner or fluoroscopy. There are some neurosurgeons that may specialize in this, and they might take you to the operating room, not because you're having a major surgery, but because they'd like to sedate you and have you be a little bit more relaxed for the procedure while they're placing a large needle near your C1 nerve root, and also near your vertebral artery. Okay, they want everybody to be calm and relaxed and not to move. That's very important, because I'll say this: if I place a needle up here towards your occipital notch, if you say ouch and move, okay, I'm just going to poke your bone here. Okay, it's not going to cause any harm to anybody. Down here, well, that could cause a significant amount of harm to people. Now, I did say earlier, for the purposes of this video, that I wanted to focus on occipital nerve blocks, but I am going to make a small digression just to make the neck area related to headaches. Over here on the right, these are common trigger points. So as many of you know, right, when you walk into my office, as I was saying, if you're one of those patients over 50 that has headaches, during the exam, I'm going to place my fingers right over these little X areas, and see where all this red is. That's where you're going to feel the pain. So sometimes it's not an arthritis issue with the neck, but if you have just a great deal of spasms, just horrible spasms of these muscles, you can see where all the pain gets referred. So sometimes we just do trigger point injections into those muscles, which are very easy to do. They're very safe to do. You basically just find the most tender point. It's like a knot right under the skin, and place the local anesthetic into those regions, and it tends to alleviate the whole spasm that you're seeing here. Sometimes there are people that have these colluses, the torticollis, where the sternocleidomastoid muscle here is very, very tight. This lateral collis is kind of extreme. For the purposes of the woman model that you see here, she is demonstrating extreme cases of collis, okay? In reality, when you have headaches, you have more subtle cases. Maybe you do have a little bit of lateral collis, but your head isn't quite stuck all the way to the right as this woman's head is. But certainly when I examine your muscles here, we can find some areas that are quite sore, quite intense. And these areas may benefit not only from trigger point injections, but also from some Botox injections. That's a different talk for a different day, and I do have a different presentation about Botox if you'd like to watch that as well. Well, that would conclude our video presentation for today. Thank you all for watching this video. As I was saying earlier, the actual physiology as to how these things work is very, very, very much more complicated than what I have stated here during the purposes of this video, but I'm hoping that after watching this, you at least have some insight or some idea as to how or why these nerve blocks work, or why we would even consider doing these to you. If you have any questions, of course, certainly contact me. I'd be more than happy to answer any questions that you may have. You can find all types of videos online on YouTube for other doctors, which will demonstrate how they perform this type of nerve block, just in case you're curious. My only warning to that is, as I've said earlier, we all kind of sort of do it a little bit differently sometimes. Anyways, have a great evening. Hope you all have a nice weekend.